We are thrilled to welcome back Dr. Rachel Caulkins today to talk to us some more about harm reduction overview today.
I'm in the clinic today.
I see a poster for Narcan behind you.
Oh, you do. And
Okay.
then there's a Sharps box. But yes, we hand out Narcan here, and I'm sure you guys have plenty of places to get Narcan.
We have it at Smart, so if anyone ever needs it, just ask us.
It's technically over the counter now, although I
Yeah,
don't know how much it costs.
I don't want to say, but it's expensive. So if you can get it free, take
So
advantage of the free Narcan if you can.
absolutely. Also, something to think about is if you've gotten free Narcan in the past, I think it expires within 2 or 3 years. In Philly, there was a syringe exchange and they would go through Narcan pretty quickly, like actually using it. And so if yours is about to expire, you can give it to an organization that they'll
That's a
use
good
it pretty
idea.
quick.
That's a good idea. We had a question with our outreach about Narcan and temperatures, if it's stored outside, freezing. Do you have any advice about that? Part of what we've done is we put it in an awning where people can get it, and it's been really cold. So we've worried a little bit about it freezing.
Yeah, that's a good question. I have in the past worried more about it overheating. Like in the
Okay.
summer, some people leave it in their car because they're like, oh, maybe if I'm driving, and it can definitely overheat and become less active, but I'm not sure about freezing.
From what I could figure out, it was like you can thaw it relatively quickly.
I do imagine that you can just have it in between your hands and it would
Yeah, it's
thaw.
not that much liquid. It's a small amount. So I figured that was probably true.
Okay. I'm Rachel. I'm in Cincinnati. Last time we talked about prescription medications and harm reduction around those specifically, but this time I'll give a general overview of harm reduction. But I tried to include actual take home points and stuff that you guys can use maybe in your day to day or teach some friends about as well. So, really quickly, the learning objectives. We'll talk about harm reduction, what it is, we'll review the core principles. And then the way that I broke this up today is we'll talk more about substance specific harm reductions or really like route of administration specific strategies. And then we'll talk about what ways that you can use harm reduction in day-to-day life. So harm reduction, it incorporates a spectrum of strategies that include safer use, managed use, abstinence, meeting people who use drugs where they're at, and addressing conditions of use along with the use itself. Because harm reduction demands that interventions and policies designed to serve people who use drugs reflect specific individual and community needs, there's no universal definition or formula for implementing harm reduction. So I got this from the National Harm Reduction Coalition. It's broad, but that's on purpose because we can apply harm reduction to so many different places in our life. What I really like about their definition is harm reduction doesn't always mean abstinence. It doesn't always mean that you have to stop exactly what you're doing. It just means you can continue what you're doing in a way that might be safer, that reduces harm. And this can be applied to things like driving a car. Wearing a seatbelt is harm reduction, right? Driving a car is really dangerous. People die all the time in car accidents, but you wear your seatbelt to reduce that harm. It can be applied to things like sex. It can be applied to things like alcohol and drugs, and it can just be applied throughout a spectrum of things that humans do, because no matter what, there's risk to everything we do. And so it's important that we reduce risk, and we have this idea of non-judgmental risk reduction. These are the 8 tenets of harm reduction on their website that I think are really helpful. So harm reduction understands that drug use as a complex, multifaceted phenomenon that encompasses a continuum of behaviors from severe use to total abstinence. It acknowledges that some ways of using drugs are safer than others. Harm reduction doesn't say that using drugs is safe. It recognizes that using drugs has risk, but it also recognizes that people will do what they need to do in their situations, and we can do things to make it safer for people. It also establishes quality of individual and community life and well-being, not necessarily cessation of all drug use as the criteria for successful interventions and policies. Stopping using drugs, or this could also apply to sex or other things, we're more focused on using drugs. It's important that people's well-being is preserved. And sometimes full abstinence doesn't preserve someone's well-being. They might not be in the right spot for that. And so it's important that harm reduction is our main goal, that people have good community and their life is being fulfilled the way that they want it to be fulfilled. It's their choice. It knows that we can't always have full abstinence for some people. It's just not an option. It also calls for non-judgmental, non-coercive provision of services and resources to people who use drugs in the communities in which they live in order to assist them in reducing attendant harm. I like that they use non-coercive here. Like, we talk about harm reduction all the time, and just because someone doesn't engage with harm reduction, that doesn't mean that they're making the wrong choice. Like, people will engage with it in the ways that it's available to them, and it's not necessarily something that people have to be doing. Harm reduction is available for people to choose what works for them, and that's like the whole purpose of the harm reduction movement. Harm reduction ensures that those who use drugs and those with a history of drug use have a real voice in the creation of programs and policies designed to serve them. I'll talk a little bit more about the history of harm reduction and kind of how it came about, but it really was built by people who use drugs and also by people with HIV, also people of color and queer people. And it's important that those people continue to have a voice in harm reduction in the movement, because not only did they help create it, but it's It's built for people who will use harm reduction. And so we don't want people outside of the system making decisions for people that are using the system. Harm reduction affirms people who use drugs as the primary agent of reducing harms, and it seeks to empower people who use drugs to share this information and support each other. It has always been a grassroots movement. It's always been about people sharing information to keep other people safe, and it's important that we keep that going when it comes to harm reduction. So by coming to a talk and taking away one pearl and sharing it with a friend or a family member, that is harm reduction, which I think is really cool. It also recognizes the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequalities that affect both people's vulnerability to and capacity for effectively dealing with drug-related harm. Harm reduction was built by people who were typically discriminated against. It uses that knowledge to continue to help those people and to serve those people. It also recognizes it looks like people have choice. We don't make decisions in a vacuum, and people's community and environments influence everything around them. And so what I think might be best for me or for someone else has no influence on what someone else is doing. I think it's important to keep that in mind. You might feel like you have the agency and the ability to make a decision for yourself, but that's not always the case for your neighbor. Just understanding that everyone is walking in different shoes and makes choices the best that they can for themselves. And then the last two tenets, we're not trying to minimize or ignore the real harm that can happen from using drugs. We know that it exists, but we just want to try to make it safer. Because like I said earlier, we can't always move drug use from people's life. It also accepts that for better or worse, illicit and illicit drug use is part of our world. And so it's kind of that same thing. It's going to be a part of our world. So we just have to figure out the ways that we can do it safely. So this is a little bit of the history of harm reduction. It started in the 1980s, and it actually started overseas, I believe, in like the Netherlands when they started to do some like underground syringe exchange stuff. But in the 80s, when the HIV/AIDS crisis really became a problem in the United States, people who use drugs and also overlapping with the HIV/AIDS crisis, they created like grassroots syringe exchange networks. This was often in the big cities like Chicago, Seattle, Philadelphia. New York played a big part of this. And it was like this underground network because people realized that this was happening. And as we know, HIV and AIDS did not get the correct attention that it deserved for quite a long time. In the 1990s, syringe exchanges started growing. In 1998, it was also recognized by the United States government. The Human Health Services Secretary deemed that it was safe and effective. However, they of course did not give any funding to syringe exchanges or anything of the sorts, but it was recognized that it was safe and effective and it helped prevent the spread of disease. The 2000s was more of the expansion of the medications for opioid use disorder, things like buprenorphine and methadone. That became a little bit more popular. And then in the 2010s is where really a lot of this took off, was when things like fentanyl came into the drug supply. And so there was a rapid rise in opioid deaths. It got a lot of attention because it started affecting white people, to be quite honest, and then more people paid attention. Because of this, because there were more opioid related deaths, naloxone or Narcan became more common, and now you see it everywhere. And then in the 2020s, Narcan's now over the counter. It's definitely more widely available and accessible. Also, there's been a lot of work done in like the drug checking services. So there's local drug supplies are sampled, and that data is distributed a little bit more, and people are keeping a closer eye on the contaminants in the drug supply. Really quickly, I just picked one person. I wanted to talk a little bit about the people who pioneered harm reduction. It is Black History Month, so I picked Imani Woods to give her a shout out here. She has since passed, but like we talked about earlier, harm reduction, it was created and made successful largely by people of color in the queer community. And I think that it's important to continue to recognize that. Imani Woods originally was like a staunch abstinence only person. She thought that people should just stop using drugs. And then she lost a friend who used drugs to HIV. She visited a syringe exchange in Seattle and then eventually founded the Street Outreach Services in Seattle. She wrote a book called Bringing Harm Reduction to the Black Community. There's a fire in my house and you're telling me to rearrange my furniture. And she talked about the ways that the challenges of getting the Black community to engage with harm reduction because of their distrust, rightly so, because of all of the harmful things that have happened to them in the past. But she was really big in harm reduction and was a national leader. So I just wanted to bring her up for a Black History Month shout out and talk a little bit about the leaders of harm reduction. Harm reduction can look like a lot of things. So here are some examples. One of the most popular being syringe access and disposal. People using clean syringes is a very important part of harm reduction. Oftentimes there's syringe exchange services and they'll give you clean syringes as well as all the supplies that you need to inject drugs, because there's quite a few supplies that are needed to inject drugs safely. Something that I often think is really important is also the sharps container, one behind me, but there's also ways that people can make their own makeshift sharps container if it's hard to get one. Some people use just like gallon jugs. It's not like the most sturdy option, but it's better than having syringes out and about. Also, people use needles to give themselves insulin, and now people use needles for like all their new injection medications. So needles are everywhere. It's helpful to have them for lots of reasons. We've already already talked about the safer drug use supplies. Overdose prevention, Narcan, we've talked about. Safer sex, medications for opioid use disorder, things like methadone, Suboxone, Subutex are all really helpful medications and have saved many lives. Safer consumption services aren't quite a thing in the United States just yet, but it's something that's been talked about. That's somewhere where you could go for supervised use of drugs. The idea is that people will use drugs no matter what, might as well have someone watching over them in case there is an overdose.
We have one of the only ones in the US in our neighborhood, which is
Oh,
very
really?
cool. Yeah, we have On Point, who we actually partner with to do our harm reduction. They have 2 locations, one in East Harlem and one in Washington Heights. They've gotten like support within the city, which is really awesome. And they do great work, and they've been really helpful with us doing our harm reduction services. So they're cool people to know, and they're doing just incredible stuff that hasn't been allowed in some cities. Shout out to them.
That's really cool. That's awesome. Drop-in centers are also helpful, just a place for someone to hang out, get resources, warm up if you need to. Maybe there's some food there. That's also considered harm reduction. And so is housing. Housing is a human right. People having a safe place to go to live is part of harm reduction. And then referrals to other organizations, whether that be doctors or local community organizations. I want to take a moment to talk about person first language. This is something that is really important to me. I try really hard to use person first language. I think this is part of harm reduction. I think that we can cause harm with our words. And I think that part of harm reduction is how we talk about people or talk about actions that people may have. So person first language, like an example would be, it would be someone with HIV as opposed to an HIV infected person. So you start with the fact that they're a person, and then whatever action or condition is something that's separate. I think that this applies a lot to substance use disorder because there's a lot of words that some people use to describe people who use drugs. For example, addict, junkie, things like that are words that I try to stay away from because I think that there's an implication that they're making a bad choice and that they're a bad person when you use those words. And when you use words like person who uses drugs or someone with a substance use disorder, it takes away a little bit of that stigma and that bias. And there have been studies that show that the way that you talk about people and the way that you talk about your surroundings influences your thoughts and your feelings. I think it's important almost as a personal exercise. It takes away that bias for yourself and it makes you reframe how you're viewing the rest of the world. It's also just the kind thing to do to talk about people in a nice way. I firmly believe that person first language is a part of harm reduction. It's really important. And I will say just historically, the medical community is not good at this. You'll meet doctors who probably have said things in a way that you really disagree with. And I am with you. I have spent a lot of my time in the medical field correcting people in the way they talk about others. So I want you to feel empowered if someone's described something in a way that you don't like, to be like, hey, have you thought about saying it like this? Because I think it's important that we talk about people with compassion. So now I'll talk a little bit more about specific substances / modes of how we use drugs. I'll start talking about alcohol. I think this is one that people forget about when we talk about harm reduction. It's legal. It feels like it's safe to use, but it's actually one of the 2 substances that withdrawal from can kill you. So I think it's really important to think a little bit more critically about how we use alcohol and the role that it plays in our life. So first, I want to talk about the standard drink size. I think this is something that we often don't think about. We say, oh, I had a drink, but it might have been more than the standard drink. And it's not really that important, but you might be drinking more than you think you are on a day-to-day basis. So one 12-ounce beer is considered a drink. And they measure these by alcohol volume, and that's why they're different sizes. 5 ounces of wine is a similar amount of alcohol to one 12-ounce beer. And then this is all equivalent to 1.5 ounces of liquor, like gin, rum, vodka, whiskey. This is important because sometimes people make themselves a mixed drink and they just pour their liquor in and they don't really realize how much exactly they're drinking. And it might surprise you if you were to measure it out a little bit. This is drinking levels defined. So technically, it's different for men and women. I know that people identify differently, but this is based off of a sex that you were born with, and it's based off of how someone's liver processes alcohol. So forgive me if this is a little bit binary. Technically, up to 1 drink a day for women and up to 2 drinks per day for men is considered moderate drinking. So that's if you're having 1 drink a day. Binge drinking is if you're having 4 to 5 drinks or more in 2 hours, and that's in a 1-day period. So a lot of times people on the weekend sit down, it's Friday night, they have 4 to 5 drinks, and it might not feel like it, but that's technically considered binge drinking. And then heavy alcohol use is 3 to 4 drinks per day or 7 to 14 drinks per week. It's technically 7 for women, 14 for men, which is a huge difference, which I find to be frustrating. And I don't know how much science is behind that, but that's technically the amount. So a lot of people have a drink a day and it feels like a normal amount, but it's technically considered moderate drinking. Doesn't mean that there's a problem, but I just think it's important to know how in the medical field, this is how I would think about drinking if someone were to to ask me about their alcohol use. So some harm reduction around alcohol is to avoid drinking on an empty stomach. As people may have learned throughout the years, if you don't eat before you drink, the alcohol affects you a little bit more intensely. So eating before you drink is important. Avoid mixing other substances. Things like Xanax, Ativan can be particularly harmful with alcohol, and also opioids as well. Safe transportation planning, I think, is a big one. In New York City, it's a little bit easier. There's a lot more public transit, so there's hopefully a little bit less of the intoxicated driving. But if you're ever not in New York City, it's something to think about. Thankfully, Uber is like a big thing now, but important to think about how you're going to get home. And then also in New York City, you don't want to be too intoxicated while you're traveling from place to place because you never know what might happen. So it's important to have awareness around you while you're traveling. That can also be considered harm reduction. Moderation of alcohol, this is hard. I think that setting goals is something that is doable. Like tonight, I'm going to have 2 drinks, and then I think that should be my limit. And just setting limits for yourself almost. This gets a little bit harder when we're getting into the substance use disorder territory because some people with alcohol, they have 1 drink and then it's hard to stop. It's like a waterfall from there, but just something to think about. And then drinking water in between drinks. 1, keeps you hydrated, hopefully helps prevent you from feeling terrible the next morning. And then also alcohol in itself is dehydrating. You're urinating out a bunch of water. It's a diuretic. And so it's important to stay hydrated. Some things you can talk to your doctor about if you feel like you consume a heavy amount of alcohol is supplementation with different vitamins. I'm not going to go over specific dosing because I think that you should talk about this with your physician, but thiamine. So thiamine is also called vitamin B1. There is specific syndromes, particularly with people who consume a lot of alcohol. It's really because if people are drinking a lot of alcohol, they're eating less food and not getting the proper nutrients, but you can become depleted of thiamine and you can get syndromes where it can lead to trouble with your balance. It can lead to trouble with your memory. It can lead to different neurological problems. And if this is the case and it's severe enough, it's not reversible. And so a form of harm reduction for alcohol would be to consider taking a thiamine supplement. Similarly, you can also have folate and B12 deficiencies, which can be dangerous, but we worry about them a little bit less than the thiamine deficiencies. But if you don't have enough folate or B12, you can also have some neurologic problems. You can also become anemic. Your blood counts might become low. So this is something else that you could talk to your doctor about taking. And then there are medications for alcohol use disorder. Naltrexone is one. This is a pill. It is safe to drink alcohol on naltrexone. Sometimes there's a misconception that if you take naltrexone, you can't continue drinking, and that's not the case. You can. It helps reduce your cravings for alcohol and decreases alcohol intake. And then there's also a few others. There's things like acamprosate, which you might have heard of. It's also called disulfiram. And this is the one that makes you sick when you're drinking. It makes you throw up. And that's how it works. There's a few others that are technically off-label, but there are medications that can help reduce your alcohol intake. It's something you can talk to your doctor about. Now I'll talk about injection drugs. I'll talk a little bit about harm reduction stuff and then stuff you can talk to your doctor about. Of course, use sterile syringes and equipment every time if you have access to them. I understand that not having access is a problem. So there are ways that you can clean your supplies if you need to, but using a new syringe every time you inject and then also not sharing with other people is important to decrease the risk of things like transmission of HIV and hepatitis C and other viruses. Also decreases the risk of bacterial infections in your skin. So if you don't have access to clean syringes, you can use bleach to clean your syringes. There's YouTube videos that were really quick and easy to watch, but essentially use your syringe and you pull up bleach into it, you rinse it out, you do it a few times. You still want to use the filter when you pull back into your syringe because bleach might look clear, but there still might be particles in there. You'll do that 3 times and then you rinse again with water because you don't want that leftover bleach if you're injecting. It is important to use a filter when you're using injection drugs. That decreases the risk of things like cotton fever and other infections, essentially. You want to make sure you're rotating your injection sites. You want to make sure you're cleaning your skin with alcohol. It's also important to test your drugs for contaminants, the big one being fentanyl. Usually fentanyl strips are pretty easy to come by for testing. It's important that when you do that, you're testing different parts of your drug supply. Fentanyl is so potent and it can be in different parts. You want to make sure your drug supply is fixed up well and that you are testing intermittently because you might have tested one spot and then missed another spot. And so it's important to continue to check. Never inject alone. If you're alone, no one can help you if you overdose. So it's important to have a friend with you, someone that can help you in case something goes wrong. And then obviously carry Narcan. We love Narcan. There's definitely more when it comes to injecting drugs, but I think that those are the big ones. If you think you might be getting a skin infection, you should see someone. They can be pretty common and they can also become life-threatening if they're not treated. They can have some long-lasting impacts. If you have a bump that's red, painful, especially if it's draining something like pus, if you have fevers, extreme fatigue, these are all reasons to go see your doctor. There are medications for opioid use disorder, like I've mentioned before, things like buprenorphine and methadone. Buprenorphine is like the Subutex or Suboxone. In the medical community, people are getting more savvy with these medications. I know in the past, people might have been using opioids and then tried something like Suboxone or Subutex, and it made you feel terrible. It put you into precipitated withdrawal. There are ways to get around that these days. I want you to know that if it's a medication that hasn't worked for you in the past, there's ways to administer the medicine. It's called microdosing, where we can get you on this medicine without getting you into withdrawal. I think that's helpful to know because it's a life-saving medication. If in the past it doesn't work, maybe talk to your doctor about it and see if there's other options. Really quickly, I wanted to talk about medetomidine. It is a new adulterant in the opioid supply. In the spirit of harm reduction, I think it's important people know that it's out there. It is similar to things like clonidine and xylazine, but it is more potent. And it's eclipsing xylazine in the drug supply. So xylazine was the adulterant where people had lots of wounds that were really hard to treat. That's now less common in the drug supply, and medetomidine is replacing it. It is used in veterinary medicine to sedate animals. There's also a version that's different. It's the same molecule, just flipped, and they use it in humans in the ICU to sedate humans. It's very potent. If people are noticing that they're needing to inject every 2-3 hours, there might be medetomidine in their supply. Also, because it's technically not an opioid, it has a poor response to Narcan. So people are noticing that people aren't responding to Narcan when they're overdosing, and it might be because there's medetomidine. People withdrawing from medetomidine often require hospitalization in ways that people didn't require in the past. So I just think it's important for people to know that it's out there. It's in the drug supply. There's a lot of it in Philadelphia. There's a lot of it here in Cincinnati. I imagine it's also in New York. Just an important thing to be aware of. Tell your friends there's new things in their drug supply, and they might notice a difference when they're using.
Can you test for it? Are there things like test strips for that yet?
Because it's
Good
just
to know.
never been something that's been frequently, like it's not on drug screens. If we do a drug screen in the hospital, it's not going to be on
Huh.
there. So there's no strip just yet that we can test
Yeah.
because it's so new and not something that anyone really expected.
So one of the best indications is if you find that you're needing to use more frequently, that could be a sign that it's in your
Yeah,
supply.
that's what I've heard. It's just so potent. I know fentanyl's really potent, but people are just like more sedated. They're just like passing out essentially.
Okay.
Yeah. And so it's hard to tell exactly, but it's definitely becoming a bigger problem. A little bit about smoking. I'm going to mix smoking and tobacco. For smoking things that aren't tobacco, using personal pipes and mouthpieces, avoid sharing equipment. There's less transmission of disease through smoking. It's just a lower risk route, but it's important to just have your own personal pieces just in case. You want to use screens to prevent burns because you are inhaling stuff that's really hot in your throat. And people do get burns. It's important to try to prevent those. Making sure your lips are hydrated and protected is important. Things like fentanyl can be in stimulants, and you might be smoking something and it could still have fentanyl in it. So that's important to know. And then specifically if you're smoking cocaine, you should also use a filter. For tobacco harm reduction in cigarettes per day can decrease your risk. A lot of times people are like, you got to quit cold turkey. And if my patient is smoking half a day and they get down to half a pack a day, that is a win. That decreases your risk. You're putting less toxins in your body. And also you can think about using nicotine replacement because cigarettes, a lot of them that makes them so dangerous is there's tons of other chemicals in there and it's getting really hot and you're inhaling all these things that are really hot and burning up into your lungs. So using nicotine replacement can be really helpful. I think the 1-800-QUIT-NOW number, you can get free nicotine products. And I think they can also help you get medications. I'm going to do a quick teaching on how to use nicotine replacement because I think sometimes people don't always use it in the right way. So you have patches and you have gum or lozenges or things that supplement the nicotine. The patches should be on for 24 hours at a time. This gives you that low level of nicotine. And then when you want a cigarette is when you reach for the other things. You reach for the gum or the lozenges. So you can use both at the same time. I think people often think it's one or the other. And based on how many cigarettes a day you smoke, we change the dosage of these things. The gum specifically has a learning curve. It's not like normal gum that you just chew on. You want to chew until it tingles and then you park it. You put it in between your gum and your cheek, and then it absorbs in your gums, and that's how you get the nicotine. If you're just chewing on it, you're swallowing all the nicotine, and it's not going to work the same. I think that's helpful to learn because you might be chewing this gum and being like, this tastes terrible, and it's not working, and it's because it needs to be parked. And the gum can taste pretty bad, so something to think about. Sorting is also a lower risk way to take drugs, but you don't want to share your straws or your bills. There are case reports of people getting hepatitis C and things from sharing straws because you have blood vessels in there, and there's some trauma. So that's that's how viruses can get through to you. You want to make sure you crush the powders very finely to reduce nasal trauma. You want to try and switch nostrils, give one side a break, and then you should also use sterile water, just a few drops after, to clean off. If you have a bunch of substance sitting there, it can almost burn your skin a little bit. So it's important to rinse it off in between. Again, you might be storing a stimulant, but there could be fentanyl in there. So you just always want to be concerned. And now there could be other things like methamphetamine in there. And then you want to use clean surfaces. So clean the surface that you're using, whether it's like a card or a razor blade, clean whatever you're using to organize it. Make sure that those are clean things, because if you're using dirty things, there's more risk for infection. I'm going to talk really briefly about safer sex. So condoms obviously are important. You can also use dental dams for oral sex. Condoms prevent infection, and they also can prevent pregnancy. Condoms can fail. You can still get pregnant and you can still get infection, but it's important to use them. Something that's important that is sometimes forgotten is to use a lot of lubricant, preferably water-based or silicone lubricant. I know there's lots of like fancy flavors and things out there, but the more basic, the better. The reason you want to use lubricant is if things are dry, there can be lots of tears that you might not see, like micro tears, and then there's a higher risk of transmitting infection. Specifically for certain routes, like anal sex has a higher risk of transmission of infection, so that's where lubricant is especially important, but it's important for all types of sex. Birth control is also something to think about. It's important to know that you may be on an oral contraceptive pill, or you may have some sort of birth control, and this does not protect you from infection. So just because you're on birth control does not mean that you can't get a sexually transmitted infection. It's important to think about both of those. So you might know that you are on birth control, but you still need to use a condom to prevent yourself from getting an infection. Things to talk to your doctor about. You can talk to your doctor about any of these things, but also a quick plug for things like PrEP, which is a daily pill you can take to prevent yourself from getting HIV. That's something that is usually very well tolerated. Once you get started, there's not that much follow-up. I think you need HIV and STD testing every 6 months, but PrEP is really useful and it's very effective. And sometimes people, they'll take it for 6 months because they know that they're going to have a few more sexual encounters than normal. And they're like, you know what? I don't need it for now. It's not something that you have to be on forever. You can be on it at different points in your life where you think it might be useful. Something else that is becoming a little bit more popular is called post-exposure prophylaxis. It's a fancy word, but really what it means is like pill in pocket. So if you are often exposed to sexually transmitted infections, or there's something that you've maybe had a few times in the past, your doctor can prescribe you a medicine to take after you have an unprotected sexual encounter. This could be helpful because, one, you don't have to go to the doctor immediately after, wait a few days, get tested. You can just take this medicine and then it essentially prevents you from getting that infection. And then also something to think about are things like the HPV vaccine. The HPV vaccine prevents cancer. It's our first vaccine that prevents cancer of any kind, but it prevents cervical cancer, which used to kill women all the time. So it's a very cool development that we have. It's safe. You can get it. And now we get it when you're a teenager, but if you haven't had it before, you can get it at any age. And it works very well. So it's something to think about. Other vaccines to think about are things like hepatitis A, hepatitis B, if you talk to your doctor and feel like you have enough risk to be exposed to that. But I think the HPV vaccine is great. If you've had a pap smear before, that's what we're checking for. We're checking for that cervical cancer. And the HPV vaccine prevents you from having an abnormal pap smear. These are some of the resources that I used. I got most of my information from the Harm Reduction Coalition. They're awesome. There's a nice article about all the people that were involved in making harm reduction a big thing, which I think is a good read.
There's a picture on our website of some of the stuff that we hand out for our harm reduction kits, just so people can see what it looks like. I think sometimes when we're doing harm reduction, we're working with a different population than our participants. So like a lot of what we talk about with harm reduction is the philosophy of it and why we do this work. But I think it's important too for people to see the kind of things that we're distributing, which they might not see otherwise. So a lot of these were things that you mentioned. So this is a picture of what has been in our safe injection kits. It might be a little different now, but this is what they've been in the past. So we have cookers, the sterile water you mentioned, fentanyl test strips, xylazine test strips, just things like Band-Aids, tourniquets, alcohol pads, just a number of different things to make sure that you're keeping the site clean, hand sanitizer. And then we also have safe sniffing kits, which include straws, the sniffing card, plastic blade, a hand sanitizer, and also sterile water. I know we got stems recently too as part of On Point. We also have cards on here that are about how to recognize an overdose, when to use Narcan. I encourage you to check this site out just so you have these tools in your pocket as well. I think this opioid overdose card is really helpful just because I didn't really know what an overdose would look like. I didn't know what the conditions were in which you would administer Narcan. So I think it's really helpful.
I think it's also important because this may not apply to you in your daily life, but you might have a loved one or a friend where this information could be
Absolutely.
helpful.
If fentanyl is in most of the drug supply right now, is it just taken for granted that fentanyl is part of a lot of the drug supply?
So, from my understanding with recent testing, there's almost no heroin anymore.
That's so
Heroin
wild.
like
Yeah,
doesn't exist. It's like all fentanyl at this
it's all
point.
fentanyl.
And so I think you'd be hard pressed to find a pure heroin sample at this point. And it's also making treatment harder because it's so much stronger that
Yeah.
we're having to change the way that we treat withdrawal and the medications that we use to treat opioid use disorder.
There's a new drug called Trank. Do you know about this?
I think the Trank, in the past, it's referred to xylazine, from my understanding.
Oh,
People are
okay.
also calling metatomidine Trank. Some people are calling metatomidine Dex because the one that we use in humans is dexmedetomidine. But I haven't heard of a really consistent street name for metatomidine. But I think that Trank, my understanding is it's referring to xylazine
Gotcha. Okay.
most of the time.
Good to know.
I know they have changed the HPV vaccine. So I got it when I was a teenager, and then I got the new one to have extra
Oh, cool.
protection. So it
Okay.
is still helpful if you're higher risk to
That's
continue
good
to
to
get
know.
it.
And also, if you have
Mhm.
a child, a grandchild that's that age, I know that there's been some pushback on that because it's, oh no, I don't want my child to be sexually active. That's not the point. The point is that they're protected before they're sexually active. And it's such a good tool to help prevent what can be otherwise a deadly cancer. So harm reduction for sure for you and for kids and grandkids and nieces and nephews and all of that.